Right. Mic testing. Hello. Can you hear me at the back? Back पे कोई है ही नहीं.
Hello.
Good. ठीक है. That's what.
नहीं रेड लाइट माने म्यूट.
नहीं आ रही.
अभी आ रही है.
11:20 हो गए. Shall we start? हम start करते हैं. 11:20 हो गए. Bismillahirrahmanirrahim. Good morning, ladies and gentlemen. So first of all, let me welcome you to our this newer kind of session, Young Investigator Forum. This is first of its kind, starting at Shaukat Khanum Cancer Symposium, and we hope that will continue this session annually, and it would reach the prestige of Alvi Medal, hopefully next time or in next couple of years. So we have invited very enthusiastic young researchers from all across the globe to present their work, not just to influence, but to inspire the young researcher here as an audience in physical, as well as those who are joining us virtually. So today we have 4 talks. 3 of those are the pre-recorded talks, but the presenters will be there with us to answer the questions at the end. So after that, we will have one in-person presentation, and we will take question answers at the end of the session. So without further ado, I will start the first talk. Dr. Fazan, would you please invite the guest?
Good morning, everyone. The first speaker we have is Dr. Oluwaseun Akinduru. Dr. Akinduru is a fellowship-trained neurosurgeon specializing in complex spine and spinal oncology. He has recently joined as a consultant. He serves as the director of spinal oncology at Mayo Clinic, Jacksonville, Florida, USA. Dr. Akinduru runs a basic science laboratory focused on finding targeted therapies for patients with spinal cancers. His clinical and research interests are drug delivery techniques for spine tumors, chordoma treatment, minimally invasive techniques for treatment of degenerative spinal conditions, as well as spinal tumors, robotic spine surgery, awake spine surgery, endoscopic spine surgery, lateral approaches to the spine, and stabilization techniques for craniocervical junction disease. The topic for Dr. Akinduru's today's talk is targeted therapy for primary spine tumors. How do we get there?
Good morning. My name is Dr. Akinduro. I'm one of the neurosurgeons at Mayo Clinic in Jacksonville, Florida. It's an honor to be able to speak with you today about some of my research. Hopefully you find it useful and helpful for your current practices and learn something new today. So the title of my talk is Targeted Therapy for Primary Spine Tumors. How do we get there? So I have no disclosures. So the goal of today's talk, one, is to review primary bone tumors of the spine and talk about some of their outcomes. We will discuss the current advances and future directions for the use of targeted therapy for spine tumors. So these are the primary bone tumors that are typically seen in the spinal column. Of course, chordoma, chondrosarcoma, osteogenic sarcoma, and Ewing sarcoma are typically considered malignant. But then you also have giant cell, aneurysmal bone cyst, or ABCs, as well as hemangiomas. So typically, these tumors present with pain, most commonly, but there are different types of pain that they could present with. So there's oncologic pain, which is typically considered pain deriving from the actual cancer cells and some of the factors that are secreted. And then there's mechanical pain, which is secondary to destruction of the spinal column and the bone. When the bone is replaced by soft tumor and the spinal column can no longer bear the normal weight, and then that leads to mechanical pain. And it's typically pain when patients are up and walking, and it usually improves whenever they sit down or lay down. And then there's also neurologic pain, which is typically considered pain caused by compression of neural elements by the tumor. That can be radicular pain or, pain in that sense. So chordomas are typically slow-growing, locally invasive tumors, but they do end up having distant metastasis, often late in the disease course. Most of the research that I do is related to chordoma. So it's a type of sarcoma. Half of them are in the sacrum, 35% in the skull base, and about 15% are in the mobile spine. That means anywhere from the cervical to the lumbar spine. They're typically in the midline, which is in contrast to chondrosarcomas, which are typically paracentral. And there are some mutations that are known to be seen in these tumors, but there's a lot more work that needs to be done to identify more targets. So the target that I'm currently working with is actually YAP, or yes-associated protein. So brachyury is positive in all chordomas. It's a pathognomonic feature of chordoma for them to be positive for brachyury. So brachyury then activates YAP, which leads to a lot of the tumorigenicity we see, and I'll talk about that in a little bit more detail. The main thing is there are no FDA-approved adjuvant therapies for chordoma. So when we look at survival, even though the 5-year survival appeared to be best for chordoma, those patients clearly appeared to have recurrence later on. As you can see, there's a much bigger drop in survival from 5 to 10 years for chordoma than you see for some of the other tumor types. So to resect or to biopsy. So we still know, based on data from before and even some of the updated, more current data, that resecting chordomas results in better outcomes. En bloc spondylectomy being the goal. But the resection, as you can see, shows favorable outcomes for all of these tumor types that we discussed, even the more aggressive tumors such as osteosarcoma. And here's a recent study that came out where they actually looked at definitive surgery for spinal and sacral chordomas over 20 years. And they identified some factors that showed improved and worsened outcomes. So large tumors, of course, understandably, are going to fare poorer. And tumors in the mobile spine, they had a worsened local recurrence. And that makes sense if you think about it. Any tumor in the mobile spine, you're going to have to worry about the neural elements. In the sacrum, you can transect, especially if it's in the distal sacrum, you can transect, cut the nerve roots, and be able to obtain an en bloc resection. In the mobile spine, there's no way you can remove all of the neural elements or all of the tissue in that particular plane. Of course, you have to preserve the neural elements, so it makes sense that there would be a worsened local recurrence. And of course, older patients tended to have a decreased overall survival as expected. So when we think about surgical planning, the first step is, of course, staging. You have to know whether they have metastasis, but that's going to change your overall plan. You have to perform a well-planned CT-guided biopsy, and you have to know where what the tract is that they used to obtain the biopsy, because you may need to resect that tract. And you need a multidisciplinary approach, including the radiation oncologist, pathologist, medical oncologist, of course, spine surgeon, and you oftentimes will need a plastic surgeon, typically, especially since there's going to be a very large gap and dead space for you to fill. Oftentimes, depending on the approach, you may need the assistance of a thoracic surgeon or vascular surgeon or an ENT or head and neck surgeon. So the Anakin classification is one that we use when trying to look at the compartments. It was originally made for musculoskeletal tumors, but has been adapted to be used for tumors like chordoma in the spinal column as well. And basically, the purpose of this is just looking at the compartments. So T0 lesions, they are confined to a capsule and don't extend beyond the borders of the compartment of origin. T1, they have extra capsular lesions either by continuity or isolated satellites in a reactive zone, but both the lesion and the reactive zone are contained within an anatomical compartment which is bounded by natural borders, such as a joint capsule, the cortical bone, for example. And then T2 lesions are ones that extend beyond the compartmental borders into the kind of more loosely bounded fascial planes without any well-defined boundaries. And then you look at grade, whether it's low or high grade. And then you kind of use this to kind of help determine what the ideal surgical strategy will be, whether it's a wide en bloc resection or en bloc resection with adjuvant therapy. So WBB classification, this is one of the ones that we use to determine the feasibility for an en bloc resection. So just to kind of a rule of thumb, any tumor that includes both pedicles is going to be very challenging and most of the time impossible to remove safely in an en bloc fashion in the mobile spine, at least. Typically, you need a tumor that only involves one pedicle. If it involves two, it may be possible, but it's going to be challenging, and it's going to be on a case-by-case basis based on the imaging. So this is just a kind of an example of a tumor that involved one pedicle, and you can see there kind of the approach to resect it. In the thoracic spine, you can typically do it in one stage from a posterior only approach. So when we look at margins, there's intralesional, which is of course suboptimal in most situations, marginal, radical, and then some situations where you need to do a limited tumor transgression. For example, any tumor that extends into the epidural space or in a tumor that involves bilateral pedicles. So here's a quick case. So this is a case actually I did with my mentor, with him. So this was a patient who was seen initially for ICA stenosis. He was found to have blood in his urine, which prompted some pelvic imaging, and then this tumor, the sacral tumor, was identified, in addition to a liver lesion. The liver lesion was biopsied. It turned out to be a neuroendocrine tumor, and the sacral tumor ended up being a chordoma. Here, you can see the imaging, a distal, a low sacral tumor. So the goal here was an en bloc resection with negative margins, which would be very feasible, especially based on how low it is. And it would be a good likelihood of minimal deficits for the patients because we should be able to preserve most of the sacral nerve roots except for maybe S4. So here you can see some of the surgical planning. We use neuronavigation for a lot of these cases and merge it with the preoperative MRI. And here you can see the surgical results. We were able to get an en bloc resection, and the patient did well with no permanent changes or loss of his urinary and bladder and bowel function. So here's another quick case. This is a patient who was doing well until he was actually in a motor vehicle collision. He developed some sacral pain right after the accident. It progressed and got worse and eventually reached out to his PCP, his primary care physician, who obtained this imaging that you can see here. So this is kind of a mid-sacral lesion, got a biopsy, it turned out to be chordoma. And here you can see the surgical result. So when you think about function preservation, ideally, if you can preserve at least one of the S3 nerve roots, um, uh, both of ideally both of the S2s and at least one of the S3s, then most people will have normal bowel and bladder function. So there are certain situations where you can take a little bit of additional time and safely remove or detach the one of the nerve roots on the side of the approach that has less tumor involved and dissect it from the foramen that it's running through and safely preserve it. And we were able to do that in this situation I don't know if you can see here. I don't know if you can see my mouse, but you can see there some of the nerve roots that we were able to preserve. And the patient had some transient difficulty with bladder function, but it did return. So here's a paper where we basically showed that even in the cervical spine, where you have the vertebral artery, the esophagus, carotid artery, all of these, challenging vascular and neural elements, an en bloc resection is still better than an intralesional resection or biopsy. So even in the cervical spine, where those surgeries are very difficult and challenging, en bloc resection is still the gold standard. And one main reason is because we don't have any adjuvant therapies that work well. There are no approved chemotherapies. And radiation, of course, we have proton, which is getting much better with proton with limited spillover into the normal surrounding high dose of radiation to be effective. So here's another quick case. This is a cervical chordoma patient. He was treated previously with a prior resection. Unfortunately, the pathology was poorly differentiated chordoma. He underwent protons, everything you could imagine, but unfortunately it did recur. So we did an anterior approach for resection of it. And at this point, the main way we were able to remove it was intralesional, just because of the nearby artery, all the vascular things around. So just an example of a situation where you have a high-grade lesion, recurrence, and an en bloc resection is not always going to be possible. So here are just some of the papers that we published in the last couple of years, showing that even though we're improving in terms of things that we're identifying to better treat these tumors, there's still a long way to go. This is a paper where we looked at targeted therapy for chordomas and some of the different clinical trials that have been completed for it. And you can clearly see in this paper that there are multiple different clinical trials. Each of these being, you can see the different clinical trials that we labeled at the top, multiple different clinical trials trying to target different pathways, but unfortunately, none of them have resulted in sustained benefits for chordoma. So why is that? So even here, there's some more studies that you can see. There's some where people are trying to use CAR T therapy for chordoma, brachyury vaccine, which appeared to be very promising, especially because if you remember, all chordomas are positive for brachyury, 100% of them. So you would think that targeting brachyury would be the ideal way to shut this down, but unfortunately, even the brachyury vaccine clinical trials have not resulted in sustained benefit. And here, just showing there have been over 70 clinical trials for chordoma. None of them yet, once again, with sustained benefits. So why haven't they worked? One, chordoma is a very firm and solid tumor. It's very challenging to get drugs to penetrate through them. It's poorly vascularized. Another reason why it's challenging to get drugs to penetrate well enough from systemic delivery. It's radioresistant, and it's, like I said, very resistant to chemotherapies. And a big part of the reason why it's so resistant to chemotherapies and radiation is actually a part of that is being driven by YAP, or the S-associated protein and brachyury regulatory axis. So YAP is a known driver of tumorigenicity for many, many tumors beyond just chordoma, actually. So if we look at it, there's breast, lung, pancreatic cancer, hemangioblastoma, the list goes on and on. YAP is a very potent driver of tumorigenicity in a lot of other tumors, which is exciting because the results of all the work that we're doing in YAP for chordoma could potentially be used for many, many other tumor types. So brachyury is upstream of YAP, and it enacts its primary effects through YAP. So my thought and our thought is to target YAP instead of brachyury, and hopefully that can result in some long-term and sustained benefits, as well as being able to apply some of the results to other tumor types. So the drug we're using is called verteporfin. It's an FDA-approved drug. It inhibits the YAP pathway. It's highly hydrophobic. It has poor solubility. And the way we deliver it is intratumoral delivery using these microparticles. The benefit of these microparticles is they're encapsulated by PLGA, and they allow for slow, sustained release of the drug over time. So intratumoral therapy, I think, is going to be better for tumors like chordoma, which are difficult to penetrate with any systemic delivery. And of course, as a surgeon, I have the ability to do procedures to, of course, inject the tumors either at the time of surgery or maybe prior to radiation in a situation where maybe the patient is too frail to undergo an actual large surgical resection. So this is just kind of giving you an idea of how verteporfin works. It prevents YAP from binding to TEAD, and that's when YAP binds to TEAD, that's when all the downstream effects occur. So it prevents that from happening. So here's a paper we published, basically showing that it works. This was on the cover of JNS Spine, and we basically found that this was in metastatic spine tumor model, not an orthotopic model. This was a xenograft mouse model, but essentially we found that it enhanced radiotherapy effectiveness and it diminished tumorigenicity for these cancer cells. And this is just a quick look into some of the results briefly, basically just showing that the drug worked very well. It shut down tumor growth, and we kind of looked at some of the different mechanisms, and I think I'll show some of that here. Here, basically just highlighting that it did enhance the radio sensitivity of the drug, especially in the intratumoral delivery. So here we compared the intratumoral delivery to systemic delivery of radiation and vehicle. So we also looked at the mechanism. So we identified, we found that the mechanism by which verteporfin microparticles are able to sensitize the chordoma to radiation is by inhibiting the DNA damage repair cascade. So anytime a cell receives radiation, it undergoes DNA double-stranded and single-stranded breaks, and that activates the DNA repair cascade. So our drug prevents that from happening, and it also increases the frequency of cells in G2M when they're most sensitive to radiation. So that's the second mechanism that we identified. Here, you can essentially just kind of see a pictograph explaining what I just said, DNA double-stranded damage to the right, and showing how verteporfin prevents DNA damage repair and sensitizes the cells to radiation by placing them in the G2M phase. Here's just a quick case, and I like this case because it's a good example of a patient who would benefit from this type of therapy. It was a very young woman with sacral chordoma, very large, as you can see, and a high sacral chordoma. So this is going to be a situation where it's going to be a very debilitating en-bloc resection, because she's essentially going to lose all bowel and bladder control just by default, by definition of the resection. So she was young, she had young kids, so of course that wasn't something that was a very reasonable outcome for her. So instead we opted for an intralesional resection. She did well after the surgery. Here you can see we stabilized her with hardware. And she did very well, but this would have been the perfect opportunity to have these microparticles that we can leave in the tumor bed and hopefully make it respond more effectively to radiation and prevent it from growing in the future. So some of the things I'm doing in the coming future, I'm going to compare systemic and intratumoral therapy in an orthotopic model, meaning a rat model where I place the tumor in the actual spinal column and treat it there. So I think that would be the kind of the gold standard to really confirm the effectiveness of intratumoral therapy versus systemic. We're looking at solubility using some artificial intelligence-based algorithms. And once again, like I said, using orthotopic model. So in conclusion, primary tumors of the sacrum and spinal column, as you can see, are very challenging to treat. There are limited options beyond surgery and radiation, so we need to identify more. En bloc resection leads to improved outcomes, but as you see, not all patients are going to be candidates or will be willing to deal with the loss of function. So we need more things to be done. And intratumoral delivery of drug may be a very viable option for treatment of chordoma and other primary bone tumors, which of course places surgeons at the forefront. So thank you all for your time. I'm happy to take any questions. I'd like to thank one of my mentors, Dr. Alfredo Quinones, and then other people who worked with me, Ziego Coslin, Paola Suarez-Mead, Paola Schiaparelli, Dr. Rosenfeld, Dr. Green, and the Green Lab. It definitely is a team effort to see, all the things that I've shown you here. So thank you all for your time.
Thank you, Dr. Akinduro. We will definitely take some questions at the end. It was an exciting talk, and we'll have some comments as well. So we'll proceed to our second talk. This one is a pre-recorded talk by Dr. Usman Bashir on artificial intelligence in cancer radiology, a challenge and an opportunity. Dr. Usman Bashir completed his radiology residency from Shaukat Khanum Memorial Cancer Hospital in 2012. He then pursued advanced fellowship in cancer and emergency imaging at both Royal Marsden and King's College Hospital, London. In 2017, Dr. Bashir completed a research fellowship at St. Thomas Hospital, where he focused on developing a machine learning algorithms to assist in diagnosing cancer through CT and PET-CT scans. Currently, Dr. Bashir serves as a consultant radiologist at St. Bart's Hospital, London. He divides his time between clinical radiology, conducting research in AI, and managing his AI startup, that is DocSmart, which he founded in 2021. He works with DocSmart's aim to empower radiologists with AI-driven tools that deliver more accurate and efficient cancer diagnosis. So let's hear from our own alumnus, Dr. Usman Bashir.
Assalamu alaikum. My name is Usman Bashir. I'm a radiologist and a proud trainee of Shaukat Khanum Hospital. We're going through an AI revolution, whether that is a smart assistant to help us organize our day, a smart car to drive us to and back from work, or it is healthcare, where AI is being increasingly used to triage patients. In diagnostics, it is being used to detect cancer and other pathology. And it's also being used to organize workflow, where a patient may come in, have a lesion that's detected on ultrasound, and then AI would interpret the report and then organize a follow-up for that examination for that patient without the involvement of anyone in between. So it's an excellent opportunity at the moment for doctors, engineers, computer scientists to come together and harness the power of AI to conceive better treatment and better care for cancer patients. And that is what I'm here to talk about. Okay, so to jump straight in. The challenge is accurate response assessment. A CT scan is typically comprised of 300 to 1,000 images, and it requires a trained radiologist to examine each image. Takes about 10 to 20 minutes, and then they have to come up with an assessment of how much disease is present in this patient. Typically, patients with cancer undergo routine assessment periodically with CT scans as they undergo various cycles of chemotherapy. And the radiologists, after seeing each scan, make an estimate of the response of the tumor to the drugs in terms of whether it is stable, responding, or progressing. Let's have a look at a case study. So this is a patient with colorectal cancer, and here I'm displaying a slice of a CT scan through the liver. The areas in dark gray are the deposits of tumor in the liver, and this is a baseline study. This patient had 4 cycles of chemotherapy, and then they had a repeat CT scan at the same level through the liver. This is how the tumor looks now. I want you to spend a few moments looking at both the baseline and the scan after 4 cycles of chemotherapy and make a mental note of whether you think there has been any improvement or worsening in tumor burden in the liver. Research committees came up with a set of rules that we usually employ in a research setting, and sometimes they roughly also translate into clinical practice. These rules are known as the RECIST criteria. What they mean is that at baseline, we select up to 10 lesions that we are going to monitor over subsequent scans, and these lesions are called the target lesions. We still make note of all other lesions. If a patient has, say, 20, 30 lesions or tumor deposits in their CT scan, we still make note of the rest, but they are known as non-target lesions. And the difference is that we do not give measurements on each report of the non-target lesions. We just give a rough estimate of whether they are getting better or not. This is to save time. So at baseline, we measure the diameters of each tumor deposit, we add them up, and we give a number. And then at follow-up, we do the same exercise for the target lesions again, and then we determine the percentage change in diameters. And the percentage change falls on a continuum from minus 100%, which is complete response, to any increase at the other end of the spectrum. And to make things more reproducible, we bin these into 4 categories. If tumor has shrunk by 30% or more, whether that's 90% or 35%, it is called partial response. If tumor has gone completely, it is called complete response. And if tumor has increased by more than 20%, sum of diameters, it is progressive disease. And then there is no end to the spectrum. It can double, triple, quadruple in size, and it's still progressive disease. And anywhere in between 30% shrinkage and 20% growth is the gray area of stable disease. I hope you can appreciate by just this description how there might be pitfalls in this kind of generalization. And that's where the lack of precision occurs. As shown in a study done in 2018, they found that up to 60% of the times radiologists may pick different lesions as target lesions. And when they pick different lesions, they may not agree in almost half the time. So I hope you can also appreciate the quandary that radiologists are in, and when we have such a multitude of lesions on so many images to go through, and why some radiologists may come to a different conclusion than others. To illustrate, in the same case, for example, reader A picks these 2 deposits in red and they measure their diameters. And then on follow-up, they decide that the sum of diameters has increased and they are in disease progression. However, if another radiologist picks up 2 different lesions, the ones in blue on the left side, and they found that one of them has completely gone and the other one has decreased in size, they might conclude that actually this patient has had a partial response. So generally speaking, this is the basis of inter-reader variability. And this is a huge challenge. A lot of the problem is because the lesions are irregular. And as human beings, we are confined to, when interpreting a CT scan, looking at only a 2-dimensional image. We don't have this third eye of being able to interpret all of the slices at the same time. That we run into these problems of inter-reader variability and lack of accuracy. And then there also is the other added problem of efficiency. We have time constraints. We do not have time to go through every single lesion and document the change in size of each and every lesion. If you did that, you would get only 2 reports out of 100 scans in a day, and the service would come to a halt. So a balance or compromise is struck between getting a good, decent turnaround time in radiology reports and getting a decent amount of accuracy, which works in most patients. And unfortunately, it does not work for everyone. As shown in this case, in reality, the drug was either working or it was not working. And based on the difference in opinion, the report would have said it's working, or it could have said it's not working. And that is a very big outstanding challenge in cancer imaging. And this also is an opportunity where AI can come. For example, if a way could be devised with the help of AI, that we could completely do away with these 4 broad categories. Because as you can think logically, a person who's responding by only 35% shrinkage in tumor is on a different part of the spectrum of response than somebody whose tumor has responded massively and only a few cells are left. Whereas in RECIST, they are both in the same category. What if we could come up with a way to classify these both in a continuum, as it really is happening, where one has a 95% response and the other patient has a 30% response, and we get something closer to precision medicine or personalized medicine, and we could tailor therapy for each patient differently and get better outcomes. As shown in this plot, this is a so-called spider graph, and each line represents a different patient and their timeline on treatment. And these numbers are plotted at different time points of treatment where CT scans were done. And the numbers above them show either disease progression, if the numbers are high, or disease improvement, if the numbers are below 0. And we can also see that actually there is also ability to map out not only the granularity, the degree, the depth of response, but we can also see the rate of response. For example, between these 2 cycles, one patient had a very steep response and the tumor size dropped massively, whereas another patient had a gentler slope in their response and the tumor is not responding as well. So that is another depth and rate of responses, another information that is present in the CT scan, but we do not currently have the means of accurately capturing it. So the question is, can AI improve our existing methods? And this leads us to the second part of my talk. In a search for better response assessment tools, we can use AI to measure the volume of every tumor deposit in the body, not just 2 to 10 deposits as done in the RECIST criteria. By measuring every single deposit with a computer, we can do this in a very short time and make an efficient service. It can be theoretically accurate, provided that there is a good correspondence between the volume of tumor determined by AI with the actual tumor volume found in pathology. The reporting can be standardized and it can be made as detailed as needed, with volumes in cubic centimeters of each individual lesion. And it can be made precise because it is no longer subject to sampling error, and it is calculating the volume of every single deposit. So in my group, we have developed an algorithm which measures the tumor involvement of the liver. We targeted the liver because A, it is the most common site of metastatic spread, and B, there is no application of AI available in the market which measures tumor volume in the liver. So, and the reason for that, I believe, is because it's very challenging compared to other body areas where CAD tools are available, such as breast and the lungs. So it shows a very nice volumetric representation of liver tumor involvement, and it counts the number of lesions, and we can also get the volumes of each lesion. The process started during the COVID lockdown, and I'm going to just touch upon it briefly. And we all know that there are lots of papers coming out, lots of new names, new words that we hear, such as radiomics, neural networks, artificial intelligence. So it really was a curiosity during lockdown that started as a laptop project for me. And then I quickly realized that there are actually quite a lot of steps that are involved in developing an algorithm to compute and detect cancer in an organ. So this is a brief overview of the workflow that the algorithm that we've developed follows. Essentially, in step one, it identifies the liver, all the voxels that are occupied by the liver as shown in these bright white colors. It draws a bounding box around the liver and extracts the liver only, which is then passed through a second model, which is a high resolution model. And the second model then extracts the liver voxels, which are colored in green here in this illustration, red being the tumor and blue being benign liver lesions such as cysts and hemangiomas. The output, when displayed, looks something like this. And our data, we have recently finished a study in our department on 220 patients with colorectal cancer, all of whom were a staging population. And we found that the algorithm had an 84% overall sensitivity for detection of lesions. And there was a total of 884 lesions. Another remarkable thing we found was that the modern AI is able to detect up to 75% of sub-centimeter deposits, which are the most likely to be missed by radiologists. There were a few caveats that need to be borne in mind before considering deploying in a clinical setting. One is that there still is a significant false positive rate. Roughly 10% lesions that the model determines are going to be benign parts of the liver or adjacent structures such as the gallbladder. So there is an essential need that radiologists stay involved even when an AI model is being used in clinical practice and separate the chaff from the grain, so to say. The big picture eventually is that we would like to have AI in the of tumor response assessment. As shown in this illustration, it would be ideal to get a tool which computes the volume of tumors and generates something like a graph here and gives a volume in CC, the changes of volumes at each time point. And from these graphs, further information and novel exploratory metrics can then be derived, such as tumor to liver ratio, which, for example, in this illustrative example is 10%. So these are never before investigated biomarkers, potential biomarkers, and using AI in these new ways opens doors for further research and possible discovery of newer biomarkers, which may have a relationship with patient survival, with patient quality of life. Eventually, we also hope that by bringing quantitative metrics of tumor involvement in terms of tumor numbers in the body or in an organ and individual lesions volumes, we could generate new types of data which could then become part of the patient electronic records. Just like hemoglobin levels are present in a lab format, we could have a CT report which could resemble something like a lab test, which could give specific quantitative estimates. So in conclusion, I believe that our current methods of assessing response in tumors to chemotherapy are flawed. And now AI and computational power has matured enough that we can seek ways to partially automate the process and develop new biomarkers which would eventually have a positive impact on the lives of patients with cancer. Thank you very much for listening.
Thank you, Dr. Bashir, for a mesmerizing talk on the AI in radiology. The next talk is also an AI-related talk and is by Dr. Joshim Starap-Hansen. Dr. Joshim Starap-Hansen is a neurosurgery trainee at the National Hospital for Neurology and Neurosurgery, Queen Square in London. He's a senior clinical research fellow at the Surgical Technology Group at Queen Square, led by Mr. Hani Marcus. He has a research interest in the development, translation, and evaluation of robotics and AI application for neurosurgery. This work has attracted numerous sources of research funding and led to the delivery of national and multinational studies spanning AI and robotics. The title of the talk is From Vision to Precision, Digital Technologies to Advance Endoscopic Pituitary Surgery.
Hello, my name is Joachim Starp-Hansen. I'm a resident neurosurgeon at the National Hospital for Neurology and Neurosurgery in London, UK, and also an honorary senior clinical research fellow at the Queen Square Technology Group, which forms part of UCL. I'd very much like to thank the organizing committee for the opportunity to speak today. I'll be presenting our group's research entitled From Vision to Precision, How We Can Advance Endoscopic Pituitary Surgery Using Digital Technologies. Starting off with some context, the National Hospital for Neurology and Neurosurgery, which you can see in this image here, is a hospital in central London, which not only is very important to myself and the other members of my research group, this is where we train, but also quite important for the national history of neurosurgery overall, as the world's very first neurosurgeon, Sir Victor Horsley, was trained in this building. Now, beyond having the distinction as being one of the world's very first neurosurgeons, Sir Victor Horsley was also one of the world's very first pituitary surgeons. And on the left-hand side, you can see an image of a craniopharyngioma surgery, which at the time required for the surgeon to use ambient lighting and instruments designed for general surgery, which therefore required Sir Victor Horsley at the time to create very large craniotomies to make sure that he could actually see the tumor and manipulate the tumor using some of the larger instruments that were available at the time. This remained the case until a few decades later, when Dr. Yasagil introduced the operating microscope, where here a lens could be used to magnify the field of view, meaning that we again required a smaller craniotomy than previously, but then also introduced some of the instruments designed specifically around this viewing angle, namely bayoneted instruments which allowed the surgeon to manipulate tissue in the field of view without obstructing the field using their hands. And then the final revolution in pituitary surgery came towards the turn of the 21st century, where figures such as Pernetsky introduced the operating endoscope. And here the tissues themselves could be viewed through even smaller incisions, often natural corridors such as the nose themselves. And there was some modification of the instruments to then allow for the manipulation of tissue through these very narrow corridors with broad viewing angles. Now, on first glance, one might assume that this introduction of the endoscope towards the latter half of the 21st century would continue to have improved the outcomes of pituitary surgery overall since its introduction. Yet, our group performed a meta-analysis a few years ago looking at the outcomes for patients with Cushing's disease since the developments over the past 4 decades. And as you can see, on first glance at least, it appears as though the outcomes for patients with Cushing's disease hasn't necessarily changed that much, despite the introduction of novel technologies. And the question is, well, why is this the case? When looking deeper into the matter, it seems as though for patients with pituitary pathologies, the experience that a surgeon has will be highly determinant of the outcomes that you are able to achieve over a larger data set for these sorts of pathologies. Below, you see a graph where the volume of surgical cases annually and the probability of achieving a successful outcome are plotted together. And you can see that surgeons that conduct over 40 operations per year have a lower risk of repeat surgery, post-procedural hemorrhage, and overall length of stay. And yet, why is it the case that experience is so heavily correlated with the outcomes in pituitary surgery? To try to get a better answer into how experience is correlated with surgical outcomes, one of my colleagues decided to look at how a particular subsection of a pituitary operation varies across the United Kingdom and how this might influence someone's outcomes. On the left-hand side, you can see the many different ways in which the skull base might be repaired following pituitary surgery, and the numbers at the top reflect the surgical practice in 27 different surgical units. And you can see that there's a huge variety in the choice of repair mechanism that a surgeon might employ, which therefore means that there's a huge number of decisions that a surgeon might be able to make across a large data set of patients. The second issue is that these procedures are technically challenging when performed in an endoscopic approach. The visualization of the tumor itself, as we mentioned previously, is expanded by having a camera that we can insert into a small orifice, such as the nose itself. But this also requires surgeons to operate at depths of the brain through narrow surgical corridors, such as the nose in most cases for pituitary surgery. And thus, if we were to take a step back, one might say that the reason why clinical experience matters so much in pituitary surgery is because there's a high number of potential operative decisions which are made during the point of an operation, and then secondly, that the execution of these decisions is very technically challenging. And thus what our group seeks to do is improve the outcomes for pituitary surgery by helping these two, or assisting surgeons in these two domains using technologies. Now, the first question when trying to define what the right decisions are to make within a pituitary operation itself is to actually define what a pituitary surgery constitutes, which isn't necessarily that simple. Our group performed a Delta consensus a few years ago to define a pituitary operation by consensus approach, in which the phases and steps of an operation were defined with a large number of international pituitary surgeons. And the output was the necessary and the optional steps involved in a pituitary operation, as well as the instruments, technical errors, and adverse events associated with this. Beyond being able to define what exactly an operation is, you also have to define what the expert surgeons are actually trying to achieve when they're making intraoperative decisions. And to do that, you have to create consensus on the outcome measures that are important to pituitary surgery. Members of our research group are currently seeking to establish a core outcome set for patients with undergoing pituitary surgery, as well as the research priorities in the coming years. The second thing is that to establish an outcome measure that not only is relevant from a radiological or from a surgical point of view, but one that aligns with patient experiences and patient priorities. And therefore, we've established a patient-reported outcome measure for patients with pituitary adenomas, so that we can align the decisions that are made during a pituitary operation and evaluate these against the once you define the steps involved in an operation and the outcomes that you're trying to achieve with an operation, you can then harness the power of technology, specifically AI, to help surgeons make better decisions intraoperatively. On the left-hand side, you see one of the AI algorithms developed in our lab, where we see a pituitary operation performed by an endoscopic transsphenoidal approach. And on the top right-hand side, you can see that the algorithm is trying to predict what step of the operation, defined as per our expert consensus previously, is currently occurring in the video itself. And below it, you can see the ground truth, which is what's actually happening. You can see that it's mapping this video quite well and is able to recognize what's happening during a procedure itself. This is particularly useful, and we'll come on to how this can be applied later on, but it ultimately allows for a digitalization of the procedure itself. On the right-hand side, you can see a further application of AI, in this case, the detection of an anatomical subsections of the sella itself, which is often notoriously difficult to delineate and to identify for a surgeon. as many of the structures, such as the carotid artery, are hidden behind bones and indentations, which aren't always obvious to identify.
We can go to the next slide.
And we can use these AI algorithms to improve the operations and the outcomes that we can achieve for our patient cohort. The first way we can do this is through coaching. On the left-hand side, you see an example of a dashboard that could be offered following an operation that has been analyzed by AI, where the surgeon can see the different subsections of the operation itself and see how long they took to perform a given operation and how many instruments they used during the procedure itself, and then use this to guide their decision-making in the future and perhaps reflect on their practice. And we've actually implemented this sort of coaching into our own pituitary practice in our hospital. On the right-hand side, you can see the cases that were performed over a given duration, and the dots represent the OSATs. So that's the objective surgical assessment of an operation, where number 5 depicts an operation that's performed perfectly, and number 1 depicts an operation that's performed as if someone has never done the procedure before. And you can see that before we implemented the coaching, which is seen by the light blue dots, the results are scattered between 4 and 5, which is roughly what you'd expect in our center. The red dots then represent once we introduce this AI-assisted coaching into our unit. And you can see that not only has there been an increase in the average OSAT performance, which was assessed anonymously by an independent third party, but also there's a significant rise just at the time when coaching is introduced, indicating that by reflecting on our practice using AI, it can improve the surgeon's outcomes over time. The second way that AI can be used to improve the outcome for patients with pituitary surgery is through intraoperative workflow support. Clearly, an operation is performed by the surgeon themselves, but it's supported by members of the team, such as the anesthetic colleagues and our scrub nurse colleagues. And oftentimes, the events that happen during an operation will influence the expectations that the team has on not only how the operation is going to progress, but also the further resources that are required. So, for example, if a large amount of bleeding occurs during the procedure itself, this will influence how the anesthetic colleagues need to react and the scrub team needs to react. It is not always easy to coordinate these different team members whilst dealing with the problem at hand. And AI can actually help with this because by automatically being able to identify events such as when bleeding occurs during an operation or the amount of time required in an operation based on the current step we're in, it's able to coordinate the teams effectively to hopefully improve the synergy and the outcomes overall. And this is something that we're soon looking to introduce at our hospital to allow for this intraoperative workflow support. The final way that we think the AI can improve the outcomes for patients with pituitary surgery is by improving the decisions that are made intraoperatively. As we mentioned previously, the outcomes for patients with pituitary surgery are defined or very much correlated to someone's clinical experience, so how many cases they've previously seen, as this can guide the decisions that they make intraoperatively, at least partially. Now, an individual surgeon has a limited timeline and a limited amount of total operations that they can see in their lifetime. But an AI system can be fed an endless number of pituitary videos, and often to the extent that they will far outweigh or far surpass what any individual surgeon would be able to achieve at any given point in time, particularly early on in their career. In our unit, we've now gathered over 500 videos for patients with pituitary operations, and thereby we're able to feed the AI with huge amounts of data, which means that it's able to detect and recognize situations that it's seen in the past. Surgeons could use this information during the procedure itself, such as when they're deciding on what certain anatomical regions are, for example, where the carotid arteries are located relative to the sella, but also whether they should be performing more of a given step prior to moving on to the next. For example, have they achieved enough hemostasis and have they resected enough of a tumor? These sorts of AI decisions or AI questions are those that our team is currently working on and has foundational models able to answer. And we think that by integrating this AI into the surgical workflow, we're able to improve the decisions that are made by an individual surgeon during their learning curve and ultimately help to improve the outcomes and the decisions made for patients at the end of the day. And once we've improved the decisions that we're able to make during a pituitary operation, we have to make sure that these are executed to the highest possible standards. And yet pituitary surgery is very difficult to perform, as the endoscope has to be placed in narrow corridors, most often the nose, which then limits the lateral ability for the instrument to move and manipulate tissue. The second thing is that the instruments designed for pituitary surgery haven't changed very much in the last years. The instruments are very often straight and don't have a wristed function at the end of them, which then limits the ability to triangulate and to manipulate tissue. This is particularly important as in a survey performed almost a decade ago across the UK endoscopic neurosurgeons, the key challenge and the key reason why they think that the operation is difficult to perform is exactly this concept of the ability to manipulate tissue, and later identify this as being due to triangulation. And that's perhaps what we need in order to better execute some of the decisions that are made during an operation, is to update the tools that a surgeon has available to execute these at all. Robotics is one solution to this. On the left-hand side, you can see a video of a grape being sutured by the Da Vinci device, which was designed for general surgery, but which has transitioned to other surgical subspecialties. And in fact, they do have wristed instruments and thus are able to afford some of the challenges that endoscopic surgery requires or laparoscopic surgery requires as a whole. However, the key challenge in applying the Da Vinci robot and some of the similar robots to pituitary surgery is that it still requires for multiple access ports, which the nose does not afford. On the right-hand side, you see an attempt at introducing the Da Vinci into the cell pathology, where it was suggested that perhaps an endoscope could be placed through the nose, and then 2 laparoscopic ports could be done by accessing gland through the eyes. Yeah, clearly, this isn't a viable solution, as it significantly increases the morbidity associated with the procedure by introducing novel cuts through the eyes themselves.
Can we move to the next slide, please?
And thus, if the surgical robots that currently exist in the innovation landscape aren't sufficient to meet some of the constraints associated with pituitary surgery, namely this narrow single access port through the nose, perhaps what we need is a completely novel instrument that's specifically designed around the constraints of pituitary surgery. Below you see the handheld robot that was developed within our group, which is specifically designed around the constraints associated with the procedure. And on the right-hand side, you can see a video of a suturing performed at the depth of the skull base. And to those familiar with robotic surgery overall, you'll know that the ability to suture is one of the most technically challenging components and requirements of a robotic system as a whole. Yet here you can see that with 2 of these robotic instruments, you're able to achieve this in a relatively short time period. And this was actually performed by one of the engineers in our group and not a surgeon at all. We performed an evaluation at the preclinical stage to see if whether this robot could then help surgeons perform the operations. And within just 5 attempts, you can see that on the left-hand side of this graph below, the expert surgeons performed to a similar extent with the robot as they did to the standard instruments. And in fact, novices who used the robot on just 5 attempts were able to outperform expert surgeons at the same stage, and were also able to do that better than with their standard instruments. While this is, of course, an early preclinical evaluation, it seems to suggest that some of the unique benefits afforded by this triangulated handheld instrument perhaps can overcome some of the technical challenges inherent in pituitary surgery, and perhaps thus improve the execution of the procedure overall. To conclude, I'd like to reflect on the last century of innovation that has happened in pituitary surgery, namely as we move from surgery 1.0, in which surgeons performed operations with the naked eye using instruments designed for general surgery, to 2.0, where we introduced the operating microscope and instruments became bayoneted to achieve the same resections, to surgery 3.0, where the endoscope afforded an increased viewing angle and changed the surgical practice away from the microscope and closer towards the endoscope, and then towards the future, which we believe constitutes 4.0, in which AI assistance and robotics can help to improve the decisions that a surgeon's able to make and the execution of these decisions using the right tools designed for the right purpose. Finally, I'd just like to acknowledge the very many members of our surgical technology group at Queen Square, led by Mr. Hani Marcus and Mr. Real Durhead, as well as many engineering associates, as well as clinicians that are able to support our work, as well as the many funders that we receive through our various research. Thank you.
Thank you, Dr. Joshin. Being a skull-based and pituitary surgeon myself, I thoroughly enjoyed your talk. I will take the questions at the end. With this, I will invite our last speaker of the session, that is Dr. Mohammad Zaman Khan Asir. He will be giving us a talk about navigating the future, challenges and opportunities for young researchers in Pakistan, a personal perspective. So I have known Dr. Zaman since my medical college, where he's known for his thirst for teaching and promoting a research culture in the medical students. His 14 gold medals in medical schools are still remembered by every Iqbalian. He did his FCPS in medicine and worked briefly as an assistant professor at Allama Iqbal Medical College before pursuing his everlasting drive for research, which landed him at Canberg Lab at University of Aberdeen, where he's about to finish his PhD. He attended Lindau Nobel Laureate meeting in 2010. He runs a startup by name Cured, which is Center for Undiagnosed Rare and Emerging Diseases. His latest work is being done about developing a novel human 3D ex vivo model to investigate early brain development. It's my pleasure to invite him. Dr. Zaman, over to you.
Thank you, Dr. Saad, for this illustrious introduction. I thought what to present, and Dr. Saad asked me to maybe share my journey towards research. So how has my journey been from the clinical practice to working in the lab? So these probably 3 landmark years are important in my journey from clinical side to the basic research. And in 2010, as Dr. Saad mentioned, I got the opportunity to attend a meeting of Nobel laureates in Lindau, Germany. And that year, there were some 59 Nobel laureates in all the fields of chemistry, physics, and biology or medicine. And there were around 600 young researchers. By that time, I hadn't published any research work. And to be honest, I didn't know really how the groundbreaking or fundamental research works, but this was one event that ignited the passion for research in me. It was the same year when I started my residency training in internal medicine. So I completed my residency in 2014, and then there was a group of researchers actually with University of Punjab. There is a Center of Excellence in Molecular Biology, which is not far away from Shaukat Khanum Hospital. And there was this group working on human genetic diseases, and it was an international collaborative effort where, as you are aware, because of the cousin or consanguineous marriages, there are increased risk and increased prevalence of human genetic diseases, especially autosomal recessive forms of these diseases. And while this is a big problem, it's also an opportunity because we have a unique genetic makeup, and the kind of genetic mutations that you might find here, you won't be able to find elsewhere in the world. And that's why we were able to publish a number of papers reporting many novel gene mutations that lead to these neurological disorders. So on one end, I was treating patients, and I was dealing with the patients and looking at the phenotype that result from gene mutations. And on the other end, I was able to find these gene mutations or variations in these genes, so to speak. But what was missing was the link, how one single gene mutation lead to the phenotype that we see. And that's when I decided to do more research and explore and do more my PhD work on the early human brain development. And that's what something I'm going to talk about. In 2010, the Nobel Prize in Medicine or Physiology was given to Shinya Yamanaka for his work on what is called induced pluripotent stem cells. So a dogma in biology was that once a cell differentiates, when a stem cell differentiates into a cell, it cannot be de-differentiated. And he was the first person to show that you can actually take someone's skin cells or blood cells that are fully differentiated cells, and then by using just 4 factors, he was able to convert them back into stem cells. And then you can use and he called them induced pluripotent stem cells. And then you can use these stem cells to make a number of different cell types. So I also work on these induced pluripotent stem cells. And what we do is we make mini brains in the lab. We make these 3D structures using these induced pluripotent stem cells. So the first study on the brain organoids came out in 2013. And over the past decade, actually, this field has exploded. And we have got so much insight into how early human brain development takes place. If you cut this organoid and look at it, it looks almost similar to how a developing brain would look like. So it provides us a great opportunity. And these are some of the organoids that we have cultured, and they show different components. So you can see the stem cells here, while you can also see the neurons that have originated from these stem cells. And on this side, the upper panel is an organoid tissue, and on the lower side is actually a fetal brain tissue, and you can see how similar these two are in terms of their composition. Now, how can we use this brain organoid technology? So we can use it to study a number of genetic mutations. You can take patients' own skin cell, convert them into these iPSCs, and then make brain or neuron or even liver cells. You can also use them to study the effect of environmental factors. And there is strong evidence, epidemiological evidence, that links that maternal inflammation, not only infections, but obesity, diabetes, asthma, environmental pollutants can increase the risk of neurodevelopmental disorders. And this has been shown that when they model this inflammation in a pregnant mice, the offspring display behavior which are very similar to anxiety and autism spectrum disorder behavior. And not only that, there is change in behavior, there are actually structural changes in the brain of the mice. But there are difficulties in translating research from mouse to humans because, one, as you're aware, the mouse brain is very flat, which is called lysencephalic brain, as compared to humans that have a highly folded brain. It's a gyrencephalic brain. And also, it is different in terms of its cellular composition. So there is one type of brain cells which are called outer radial glia cells. Essentially, these are brain stem cells, which are much more abundant in humans than mouse. So obviously, the studies from mouse cannot be directly translated to humans. That's why many clinical trials, that's why many drugs do not reach the efficacy when they are tried in humans. So to overcome these limitations, a number of human-specific models are being used, and these are 2D as well as 3D model systems. So you can take these iPSCs and convert them into any cell type, but it's still 2D. Your brain is not 2D, your brain is 3D with a complex environment. And that's why we also work on the brain organoids. But one of the problems with brain organoids is it has all the neural components, but it does not have a vasculature. It does not have microglia, which are the immune cells. So if you want to study the immune and neuronal tissue interaction, it's not the best model to do that. Well, the third thing is you can take the actual brain tissue and you can slice it, which is called organotypic slice culture, which is the closest you can get to human tissue. But the problem is it's not high throughput. So if you want to study many things, you want to study the molecular mechanisms, you want to do a number of immunofluorescent stainings and study the cell behavior, that's not well suited for that. So during past 3 years, what I have done is we have access to electively terminated pregnancies where we get access to the human fetal brain tissue. We focus, we get the tissue from gestational week 8 to 20, but we focus on the mid-gestational time point. And what we have done is we take this brain tissue and we chop it into the small pieces, ensuring that it has all the layers of a developing brain, which is on this side is the ventricular zone, which lines the ventricular surface. And on the outer side is the cortical plate, which is adjacent to the meninges. And then what we can do is we can put them in a culture media, and then we shake them on an orbital shaker. Now, when we shake them, it ensures that oxygen and all the nutrients are going through into this. And this is how it looks like after 1 to 2 weeks of culture. And then we can cut this tissue into hundreds of sections, or we can use it for a number of downstream analysis. And we call this a cerebroid. And we have shown that if you cut through a cerebroid, it has all the layers as you would expect from the developing brain. But even after 1 to 2 weeks of culturing, not only it keeps on growing ex vivo, it also has the same polarity. And this polarity is important. If you disturb this polarity, it can result into a number of neurodevelopmental disorders. So if you look at closely, you can see in red color are the stem cells. In yellow color are your neurons. So they are on the two opposite sides. So this polarity is maintained. And what we can do is actually, if you look at these stem cells here, we use an adenovirus that can selectively infect these cells. And then these cells start expressing GFP. So we genetically engineer these cells, and they start looking green, and you can see. And a characteristic feature of these cells is that they have their cell body in the ventricular surface, but their processes go all the way to the cortical surface. And this is to ensure this is like a rope along which these neurons, newly generated neurons, can climb and go all the way to the top. And then we confirm that not only that these cells are there, they are actively proliferating. So by Ki67 staining, you can see they are proliferating, and this is a comparison of fetal and the cerebroid tissue, and this is comparable to how they would be proliferating if the tissue was still part of the fetal brain. And by using something which is called EDU pulse chase experiment, you don't have to know the technicalities, but what essentially now we can do, and this is a technology on which 2 or 3 years back Nobel Prize in Chemistry was given, that you can actually use EDU, which is an analog of thymidine. So in your DNA you have A, T, C, G. So in place of T, you can give EDU. And if a cell is synthesizing new DNA, which means a cell is proliferating, it will incorporate this EDU, and we can detect this EDU later on. So we can actually use this to trace the lineage or the progenies of these cells. And we could see that not only they're proliferating, they are generating new cell types, the neuronal precursors, as well as the actual mature neurons here. This is a scanning electron microscope, and it might be a bit tricky to appreciate here, but you can still see their characteristic features, their long fibrous tracks. And this is a transmission electron microscope, and you can see those processes here as well. What it essentially shows is what we were able to demonstrate was that in our culture system, you can actually recapitulate the same cellular phenotypes as you would see in a developing brain. Not only that, it also has microglia. So these bright dots here are microglia. It's a high resolution image. And this is a transmission electron microscopic image. You can maybe appreciate these small bodies inside these. These are all phagocytic vesicles. And that's what microglia do during the development. You have other cells like astrocytes or astroglia, oligodendrocyte progenitors. And most importantly, you have blood vessels. So there is no circulatory system. So blood is not flowing anymore. But you know that these cells, endothelial cells and pericytes, are more than just a conduit for the blood flow. They play important regulatory roles. So we could see that there are these blood vessels there. And even at the ultrastructural level, they maintain the same features as you would expect in the developing brain. So this demonstrates that now we have a model system which is the closest we have gone so far to actual developing human brain. And then we use this model system to study the effect of maternal inflammation. So we used a cytokine which is called interleukin-17A, which is central in mediating these effects. So we made these cerebroids and treated them with interleukin-17A for a week. And after a week, we harvested them. And the first thing we made sure that this is a transcriptomic data or mRNA expression data, sorry, from the microglia that were in this cerebroid. And on this side are all the genes that are upregulated, and on the left side are the pathways these genes relate to. And you can see a number of inflammatory pathways get activated in response to this interleukin-17A. Quite a striking phenotype was that when we add interleukin-17A, we started to see more folding taking place. Now, at gestational week 12 to 14, you don't see folding. Folding takes place usually at later time point, at around 16 to 18 gestational weeks. But we started to see it quite early, and this is a scanning electron microscopy showing the same. So we actually quantified, so this is the vehicle versus interleukin-17A treated cerebroids. And you can see we measured this gyrification index, which is the ratio of this fiducial as well as the convex hull length. And we did find that this was significantly increased. Not only that, actually, you can see the total thickness of this cerebroid is increased. And if you look more closely, you can see that this middle layer is the one that is expanded the most. Cell density is different, which means there is probably a change, not only in the cell population, but in the extracellular matrix of the brain as well. We also found that if you compare the neuronal layer here versus interleukin-17A, the number of neurons is increased. And not only the one type of excitatory neurons, but different types of excitatory neurons are all increased. And we looked at these neurons, and you can see their firing rate. They were more mature as compared to. So not only that we were getting more neurons, but these neurons were more mature. They were maturing early in response to maternal inflammation. And again, the same EDU pulse phase experiment, we showed that actually more EDU positive neurons were seen. That means this increased number of neurons is because more neurons are being synthesized after we add interleukin-17A. But is this effect dependent on microglia? So to confirm that, we use organoids. As I just mentioned, they do not have microglia. And when we treated them with interleukin-17A, we again saw an increase in the number of neurons. So now you can see that we can complement different model systems to answer different types of questions. But still, organoids are complex model. They have many cell types. Is it cell autonomous effect? So in order to do that, we actually use the neural stem cells, and then we treated them with interleukin-17A. And here, these are neurons in interleukin-17A treated group, which means this is a direct effect of this cytokine on neural stem cells. So we looked at, now we know what is a cellular mechanism, but what is a molecular mechanism? And can we target something? And in order to do that, we dissociated these cerebroids into different cell populations, and then we looked at their gene expression pattern. And what you can see in this a bit complex plot is on this side are the genes which are overexpressed in response to IL-17A, and these genes which are underexpressed. And many overexpressed genes belong to extracellular matrix. So not only cell populations are important, but their environment is probably changing in response to interleukin-17A. And in the neural stem cells, what we saw was there were changes in gene related to mitochondria. So on one end, the extracellular matrix is changing. On the other end, it's the energy metabolism of the stem cells that's being changed. So we said, okay, let's break down the extracellular matrix, and by proteomic analysis, look at which proteins are actually high. And what we did find that these are proteins that are high, but BCAN and VCAN, some of you might be aware, Brevican and Versican, which are an important hyaluronic acid binding proteins that were quite high. And we confirmed it with different staining and electron microscopy that actually these proteins, or these glycosaminoglycan containing proteins, quite a mouthful name, but yeah, they are increased in response to interleukin 17A. Well, now that we were able to, for the first time, see that how actually inflammation affects the developing fetal brain, the question is, can we target any of these pathways? So in order to do that, what we did was we looked at all the genes that were up or down regulated. And along this axis, you can see the transcription factors which regulate the expression of those genes. And we found, while it's not readable, we found that two important pathways, NF-kappa B, which is a common pathway, nuclear factor kappa B pathway in inflammation, as well as histone deacetylase 1 pathways were involved. And we found that there is actually a natural derivative drug, parthenolide, which is derived from feverfew plant, has an ability to inhibit both of these pathways. So we treated with interleukin 17A, but also treated with parthenolide to see whether we were able to rescue this phenotype. And actually, there was folding in interleukin 17A group that was gone when we added parthenolide. And again, here, this is the normal, this is interleukin 17A, but when we combine interleukin 17A with parthenolide, you can see that this phenotype is gone, and this is just the quantification of that. So we were able, by using parthenolide, we were able to rescue this phenotype. And by doing staining, so in yellow color is actually the Brevican, and you can see in interleukin 17A, the Brevican is quite high. That went down when we added parthenolide. So to summarize, we use a new model system, and we used that to study the effect of maternal inflammation. And we found a number of changes, including remodeling of extracellular matrix, changes in cortical folding, microglia activation, etc. So what have I done so far is, the reason I went into research is the curiosity. How you can lead your research is by finding the research gaps, but also what are your strengths and opportunities in your system, like I said, genetic background of our population and prevalence of these diseases, and find the right people to collaborate with. At the end, I would like to thank all the funders and collaborators with which I did this work and was able to do this work. Thank you very much.
Zaman, for a truly mesmerizing talk. I'm really spellbound. I'm sure the audience thoroughly enjoyed and learned from your work. We would like to take the questions from Dr. Zaman first, as he's present physically.
Thank you, Dr. Khan. Excellent job. Certainly, much of it is beyond our reach and working as neurosurgeon. So, we realized that technical neurosurgery, of course, your talk was related to the brain development, but we know that they are continuing to wide in the brain, partly responsible and are responsible for our memory encoding and brain memory. So, would that be another aspect of the research in the developed brain, look for targets or tumor dementia, and other
Thank you very much. So human hippocampus is at least one of the three identified areas where ongoing neurogenesis takes place. And one of the things that our lab is establishing at the moment, we have made the hippocampal organoids as well. And that's something that we want to study. But one of the reasons presenting this work was, if this is something that can be done for the normal fetal human brain tissue, this can be done with the tumor tissue as well. So by following the same technique and just optimizing a few things, we can culture the resected tumor tissue. And this can be a great opportunity, at least for the fundamental research, to try different drugs, so to characterize what molecular pathways are being activated in this tumor type or in this tumor tissue, and then screen a number of drugs. So you can see in the lab which drugs or molecules are most effective at decreasing the proliferation or killing or inducing apoptosis in these cells. And that's something I was discussing with Dr. Saad the other day, and that would be something that maybe in future we can collaborate on. And as Dr. Saad was mentioning, the burden of cases, the tumor, brain tumor tissue that you're getting at Shaukat Khanum is probably the highest number of, especially in the pediatric population, at least many tumors that you're getting. So it's a huge opportunity to actually try and see if we can screen these drugs. So we are, well, this is something that we use for maternal inflammation, but we plan to use it for other systems and other diseases as well.
You have a long research journey. So I just want your thoughts for a country like Pakistan, where it's very difficult to generate knowledge, and the kind of cultural background that we have for the research, and the hurdles that young investigators face every time. So what are your 3 points they want to deal with this young generation about to generate new ideas, and how to execute them?
Yeah, I think it's a very pertinent question. And what I have noticed over past 14 years by working with different people is one of the opportunities that we are missing on the clinical side is the ability to collaborate with people. So I found there are so many people working on the fundamental sciences or on the genetic diseases or on the tumor. Actually, there are many PhDs working on this. And the problem they are facing is they have difficulty enrolling patients. They have difficulty finding samples, which we clinicians have on daily basis. And we want to do the research, but we are not in contact with those people. I think the biggest thing, we are very busy, and especially you are very busy, clinicians are very busy. Research needs some dedicated time. And there are people out there whose only job is to do research, but what they do not have is access to these things. So one thing that we can do is probably, if we can link these institutions, if we can bridge these two departments, your research output can greatly increase. So just past week, I was invited at Center of Excellence in Molecular Biology at Punjab University, and they're working on tumors. They're not far away. They're working on oncology. They're working on these genetic and molecular pathways. And perhaps they are really hungry to collaborate with clinicians. So I think this is one area that can be worked on too. They get the funding that we do not have. And the second point is international collaboration. So there are only 2 or 3 funding bodies for research, and the funding that you get is only nominal. But through collaboration, so regularly there are UK, Pakistan collaborative programs. I think they go away because there are not many applicants. Same is true with so our group that was working on human genetic disease was collaborating with researchers at Johns Hopkins, University of Maryland, through NIH funding. So they were not dependent on funding from here, but they were getting funding through their collaborators from there. So these are, I think that's the only way to overcome these limitations. There was a question.
There's one more question from that lady.
Yeah. Yeah. Alaikum salam.
I'm a research student at Precision Medicine Lab Peshawar. So I've been working on a brain tumor, medulloblastoma, and I wanted to ask one thing. I joined in the middle. I wish I could be here from the very start. The work that you mentioned just here, is it all published or is it a preprint available so that I can just go there and have read?
Yeah, so this is all unpublished work that I have presented here. Just this week, we are submitting this work to a journal, and we will also put it on bioRxiv. So,
okay, so I would love to read that.
Yeah, sure.
And one second thing, I do all the bioinformatic analysis, and once you do the dry lab work, then your next step is to go to the wet lab. So what will be the first step that you shift all the analysis from a dry lab to wet lab? I mean, like in a country like Pakistan, like what will be the first step?
Well, I would recommend doing when you get vacations, doing some internships at some research institutions. spend some time there and see whether even wet lab work is for you. Maybe you might be better on dry lab work. And again, all the work on AI, I mean, at least this can be done here. You have access to like what AI requires is some input, and I'm sure you have plenty of that input. What you need is people who can develop these algorithms, and they're not also far away from you. So I know many groups at FAST University who are working on AI. And if I can be a bridge, I mean, I'm happy to help. I know many people work.
There's one more
question.
Yeah.
Assalamu alaikum and good afternoon, everyone. I'm Farah Asif and I'm oversee clinical research office in Shaukat Khanum Hospital. So thank you for the wonderful talks. So my question is primarily related to AI. So with the advent of AI, there is a surge of research projects and interest where they are requiring data because we're a custodian of very good quality data in our hospital, including the imaging data. But at the same time, we came across certain groups who do not plan. So my question is slightly different note. It's around the regulatory environment, looking at the AI currently. So there are few groups who lack the vision at times, or the capacity, or they do not plan to complete the complete regulatory approval process. And yet they are they are interested in developing collaborations. So how to deal with that situation? And for example, you just mentioned that there are students and there are universities. So at times there are students who are wishing to get their hands on the data, but we can believe that we are not sure if they can, compete and complete the regulatory processes. And so what are the guidelines here? I understand that regulation is a national matter, but it would be important to know that, how to deal with these situations where we receive expressions of interest, like numerous expressions of interest, but how to identify who is the authentic collaborator and where we can safely contribute our data. So that would be grateful if you could answer that. Yeah.
I can answer part of the question, and then we
Yes.
have more experts
We
on
will
AI in the panel who would, amongst the speakers, who might be able to answer that question. But because not necessarily with AI, but also with the other research work, there are many people who are interested in doing research and getting the data, actually the regulatory approval. And what I would say is one of the responsibilities of researchers is research integrity. And all these, I think these guidelines are to ensure that anything that you are doing is ethically doing any harm to the patient confidentiality or for example, patient care. And for an institution as mature as yours is, with the well-established ethical review board for this approval, I would recommend that rather than working with the students who are not very familiar with these regulatory processes, I would recommend collaborating with established researchers. And obviously their students can work under them, but when you try to establish the collaboration, that has to be, so maybe you are working in an area that on the clinical side what are the ethical obligations, but from the research perspective, maybe the other person is more experienced across what are the national or international guidelines on that. So I would strongly recommend in that sense, first establish the research proposal with required approvals, and only then, sometimes it takes go away. So that's why it's important to work with the established researchers, and maybe as our
And
colleagues.
at times,
We would
these
like-
are organizations, commercial organizations as well. So yeah, I would like to hear from Dr. Usman.
Yeah, Dr. Usman, if you could give your valuable comments on this as well, please.
Can we unmute Dr. Usman, please?
Sorry. Okay, I've unmuted myself. Can you hear me?
Yeah. Sorry,
Yeah,
earlier.
So basically, what you're asking is how to ethically do this so that the patient confidentiality, which is the main concern, that is protected. And the other way, and the other question seems to be how to ensure that these people are actually going to deliver on the projects that they are proposing. Did I understand you right, or is there anything else that was in the question?
Yes, you have understood the question rightly, and consider that I'm speaking on the side of from the side of IRB, as well as we are the ones who are responsible to ensure that regulatory compliance is always ensured. So from that perspective, so I'm sitting on the side of IRB and regulators.
Yeah, so I think I can speak on imaging data. What we do at BARTS is that we have a data protection impact assessment form, and I can check with my organization, and if it's okay, then I can maybe share some of the critical things about it. But the main thing that they want to ensure is what is the potential impact on the patient's care on doing this exercise, and the impact comes in terms of proposed benefit of the that is being proposed. So, and how do you ensure that it is going to be delivered? Generally, I don't think that it is policed. People take away data, and and it happens. They don't deliver. What usually the things that do that help is seeing a well-designed synopsis of the research study, seeing a full protocol. Sometimes a requirement is that you send. Then they can add in additional checks in place to basically the idea is that they gauge that the people who are asking to do the study, do they have the resources and do they have the expertise to do it? So they might ask for the CV, but all in all, you can't, it can't always be guaranteed. And I don't think that organizations take a very huge sort of responsibility for ensuring that the team that is taking on the project is actually going to deliver. So they do a little bit of due diligence in making sure that, there's a team composition in place, like having a statistician who's, signed off the protocol and so on and so forth. And they also ask for these sort of, once you've registered a research project, they will ask for regular updates. For example, a 6-monthly review and stuff like that happens. With regards to data protection, there are very tight regulations in the UK, but some of the things which the information governance does to ensure that there is minimal to no harm to the patient is basically, for example, what I do for my research is that I anonymize the data sets. So before the data set leaves the trust, that is, I think it's a very, very key thing that has to be done, is that there can't be any room for allowing any patient identifiable information on data that leaves the trust. So it has to be, the patient information has to be taken out of it. And finally, I can add that one thing that BARTS, where I work, is doing now is that they're hosting their own secure development environment on the cloud, where all the research is done within the BARTS sort of IT inside the BARTS firewall. So that adds another additional layer of protection for patient identity.
Thank you, Dr. Usman. Thank you so much. So I understand there are challenges that, of course, we cannot fully control this. And another anxiety that we would have is that once we give away data, we would lose the control and we would not know how this data is being used. But at the same time, so yes, data visitation rather than data sharing, data visitation could be an alternate, as you have suggested. So thank you. Thank you so much.
Dr. Mena has a question.
What a wonderful research and wonderful talk you gave. It reminded me of my PhD when I was developing breast cancer mammospheres from breast cancer cells in 3D structures. So I'm just wondering if the tissue that you use, the brain slices, is that right after surgery, or do you freeze them and then you can redo them, or do you take them straight to culture? That's what I was wondering.
Yeah, so what we do is we work on the fresh tissue, So we are physically situated just next door. Our lab is just next door. So what I haven't shown, but we usually start culturing within 2 hours. So within 2 hours, they are already in our culture system. And that's why we see that they keep on growing. One thing that we want to try is we want to freeze it down and then thaw it again and revive it. So this has been done with brain organoids, but haven't been done with this fetal tissue. Because if we are able to do that, then at the moment, only we can do this, and not many other people can work on that. But if we are able to freeze it down and then be able to revive it, we can maybe transport it within the bounds of the approval to another lab, to our collaborators who can do some other experiments.
Thank you. I have a question from Dr. Usman. Are you planning to do any collaboration with SKM on AI in radiology?
I would absolutely be delighted to enter a collaboration with SKM. I am actually, I've just finished technical validation of a liver detection algorithm, and the plan is to do a whole body cancer detection. And part of sort of getting a well-structured devices to get a global sort of international collaboration where you have multiple centers. So absolutely, that is something I would very much look forward to if possible.
Dr. Usman, Dr. Faisal here. I'm consultant head neck surgeon at Shaukat Khanum. Good to see you. You know, I'm sure you are aware of it, that we do offer induction chemotherapy to our patients, and then we see their response through the images. So I think it will be a good idea to actually have a collaboration on that, because the response is very variable. And then I just heard your talk, and as you suggested, that AI has a bigger role to play when you are actually gauging the response from partial to good to excellent. So this is something in my mind that we should look forward to, and I'm sure you'll be on board for this project.
Yeah. Is there any project that's already in the working at SKM?
No, this is something in my head right now.
Okay, sure. Why don't we maybe if you can email exchange, we can take the conversation there.
Sure. So thank you. With this, I'll end this session. I'll thank all my speakers, Dr. Akinduro, Dr. Usman, Dr. Jashin, and Dr. Zaman Khan. I think the purpose of this session was to stir the curiosity, and I think we have achieved that. Hopefully, in next coming years, it would be a bigger session and with more interaction and with more speakers. So thank you all. Thanks all the audience which are here physically and virtually with us. Thank you.
Thank you, Rahman.